I'm Rossitza Chichkova. I'm a neurologist. I'm an associate professor in neurology and internal medicine at the University of South Florida in Tampa. Many people think South Florida is somewhere around Miami, but University of South Florida is in Tampa, Florida. I teach students, residents, I teach patients, I teach peers on any topics in neurology, including neuromuscular medicine, and of course inflammatory myopathies are one big group of diseases within the realm of not only neurology, but of course neuromuscular medicine. So today, first of all, I've been speaking for the last 4 years for the TMA, and I really enjoy interacting with you guys. And as I always say, this is the most challenging type of talk that I have done, because when I speak to patients, I am probably the most uncomfortable because you guys know more than me. When I speak to students, residents, or peers, they don't know more than me. I know more on the topic, but you guys live with those diseases and you wake up looking on the computer, looking for new stuff, so you challenge me, and that's what I enjoy. So I learn from you too. Now the other thing before I start talking on today is I would like to thank Option Care for bringing me today. I've been friends with Option Care for many years, before they were called Walgreens, but they changed their name. I have kind of same friends under different names. So really thank them. I have a lot of patients who are under their care, and I enjoyed collaborating with them for the last several years. So today I'm going to speak about complications in inflammatory myopathies. I'm fairly sure that you hear a lot, many of the things, but I kind of decided to put several important topics together. As you know, there are different complications that one might have. On one side, these could be related to the disease itself. Another big group is complications related to therapies, because many of the therapies that we use have different side effects and complications that could occur with it. And of course, complications of both, related to the disease and related to the therapy. And I know you know a lot about complications of drug therapies, but I kind of want to focus on things that are related to the disease itself. And I put a little thought about that. I kind of thought about possible different complications, not only the common ones, but some kind of even more unusual ones. So difficulty with swallowing, as you know, many of you may know, and have experienced that problem, swallowing food, swallowing liquids may be hard, for folks who have no problem. This is an automatic thing. You just drink something, swallow it, and you're done. You enjoy your food. You don't have worries that something may go into the wrong pipe and you may choke and have complications. So in order to do that, we have voluntary muscles who tell the food, okay, go back. But from there, the esophagus, which is the pipe that comes right after the mouth, it has kind of smooth muscles that are under control of different parts of the nervous system. And of course, that muscle, in some folks who have myopathies in general, and in this situation, inflammatory myopathies, could be affected and may not be working synchronously with the muscles, voluntary muscles here in our throat. And as a result, like I said, we call this, we have a fancy term, just we have fancy terms for many things, but it's called dysphagia. So dysphagia results, or difficulty with swallowing, is a result of that. And patients may have through choking, but sometimes they start coughing, and many times patients don't pay attention to that fact that they simply have a cough. They don't think that this is serious, but it could be a sign of actually food going or liquids going into the wrong spot. And heartburn is another thing. If patients have serious problems with swallowing, they could become malnourished. And malnutrition leads to catabolic state, meaning in order to fulfill all those needs for energy, you have to start breaking your own, first fat, of course, but muscle. And this is not what you want if you have problem with muscle as a medical problem that patient. Then they start losing weight. And when you start losing weight, this creates more weight. And of course, when you develop a state of malnutrition, different vitamin deficiencies can also occur as a result of that. And then vitamin deficiencies, you know, when we think about vitamins, we're like, vitamins, who cares? But vitamins are very important components in different reactions. Important in reactions that are really important for the integrity of the nervous system, integrity of the cells themselves. So that's why we really care about this issue. It is very important to have very early recognition. Do not ignore those early signs of throat choking and throat coughing. And swallowing evaluation should be done. Now the swallowing evaluation, if you say, oh yeah, I had swallowing evaluation last year. Last year was for last year. Maybe this year there is some other type of problem. Maybe there's more problem this year. So within the same individual, the swallowing evaluation may show different results over time. And also, the recommendations are not the same for one patient versus another, because the speech therapists, they're very instrumental. They can give very important recommendations to the patient how to swallow. And those of you who've been to speech therapy, they tell you, tuck your chin or do something, or turn your head this way or that way. They can show you tricks, because they know how your food penetrates the esophagus safely, and they could give you those recommendations that later on you can follow at home or anywhere you are. And important also is for folks who have trouble clearing their throat is to elevate the head of the bed a little bit, so that even at night, you know, juices from the stomach can go up and down. This is how you develop reflux, and this reflux is much more intense. And of course, if you are flat in bed, the juice can go all the way up to the throat and then to the breathing and cause problems. And what are the complications of that? The swallowing problems. Of course, aspiration. Like I said, food or liquid going to the wrong part, meaning to the breathing, to the trachea, aspiration, pneumonia results. Because believe it or not, the mouth is one of the dirtiest places in the body. There are so many bacteria in the mouth. And if somebody has bad teeth or bad gums, these are really bad bacteria that can go directly to the lungs. This is something that we want to prevent. And of course, you can choke on a piece of meat, and that's called asphyxia. Now, there are so many dysregulation of the function of the esophagus. In some situations, it can get tighter. In other words, we call them strictures, like in this case. And above, the esophagus can become larger. Also, there could be ulcers of the esophagus that develop. See, it should be nice and pink, and this is really angry esophagus, really angry esophagus. It's called esophagitis. If this is just inflammation, and if you see clear ulcer, of course it's called ulcer, which is necrotic tissue developing as a result of this constant irritation. So aspiration pneumonia, if you would appreciate, you don't have to be a doctor to see that there's something wrong with this lung. You see how nice and clean this area is, and you see really bad spot, white spot here, which is an example of aspiration pneumonia as a result of this food or saliva going into the wrong place. Some of the signs of aspiration pneumonias are, of course, fever, chills, cough, some sputum, yellow or green. But you have to be very cautious. Patients who are on immunosuppressants may not have all those signs of infection like people who are not on immunosuppressants may have. So they may have suppressed effect, just like the immunosuppressants suppress the reaction, the autoimmune reaction. They also suppress all those signs, the presentation of an infection. In other words, they may not necessarily have fever and chills and big time pain. Patients who are on immunosuppressant even may perforate the gut and not feel it. This is how much the pain would be suppressing those folks. And keep in mind that aspiration pneumonia is #1 cause for morbidity and mortality in hospitalized patients. And it is a serious issue, of course, in non-hospitalized patients. So prevention is the most important thing. I'm not here to scare you. I'm here to empower you, to know what could happen and how we can prevent it, and what we can do ahead of time, not wait for the pneumonia to occur. That's why pay attention to the swelling, address it as early as possible. Breathing problems, as you know. Now the chest muscles, many people think about breathing only about diaphragm. Even students, when they talk about, oh yeah, the diaphragm. The diaphragm is not the only organ that participates in the breathing. The chest itself. You've seen chicken bones, right? The breast bones of the chest of chicken. There are small muscles in between the ribs. These are very important muscles because they are the ones that help the rib cage expand. Therefore, the lungs will also expand when we inhale. And when we exhale, the rib cage constricts, and also the lung gets smaller, and we exhale the air out of there. Now, in neuromuscular diseases, including in myositis, this process may be a little bit dysregulated. And may not, all these muscles may not work so synchronously together so that they will ensure proper aeration. So if you don't get enough air into your lungs, if you don't breathe deeply, air doesn't go all the way down. So what happens is this creates occasional collapse of those tiny little, we call them alveoli. The trachea then splits, it's like a tree with many branches. And imagine the leaves are all those little tiny vesicles, like bubbles, where all the important processes start, where the oxygen from the air gets transferred to the blood and goes everywhere. So if those areas collapse, this leaves the patient with less volume. So this means when there is demand for more air, there is not much volume because everything is kind of blocked and closed. So that's why breathing is really important. The affected patient can have shortness of breath with higher demand or even at rest. And of course, in severe cases, this would lead to respiratory failure. Breathing is always worse at night because we are kind of on autopilot at night. We don't know what's happening, right? During the day, we can make effort to breathe deeper, to cough, to exhale, kind of to exercise our lungs. But what happens when we fall asleep? We don't know because we are kind of in unconscious state, right? We could be awoken from that, but we don't know what's happening. That's why patients who have breathing problems, the worst part of the day is the worst part is the night because they lose that control. And many folks can also have sleep apnea. So in addition to the weakness of the muscles, sleep apnea may be contributing to this process of decreased oxygen going into the brain and other organs. I keep talking about the brain not because I'm a neurologist, but the brain is the most important organ. Because if you have no brain that is alive, you're not a person anymore. You're just a body, right? In this day and age, we can keep people alive, but we definitely want to make sure that the brain works properly and gets all the nutrients. So this, like I said, decreases the blood supply and the oxygen to the brain, other vital organs. So that's why spirometry or breathing, testing of the breathing parameters is very important. There are tests with different complexity. Some are more complicated. Of course, sleep study can be done. Folks who smoke, it's better to quit smoking because, again, smoking gives, instead of giving oxygen, gives all those carbon dioxide, different other gases and toxins that further compromise the proper function of the brain and other organs. So when folks have difficulty with breathing, this is not necessarily a mechanical problem. I want you to know that there may be you can name other reasons for folks to have breathing, not just weakness of the muscles and whatnot. Don't forget, difficulty with breathing could be simply lung disease, could be heart disease, could be water retention from kidney disease. So there are many reasons. So this is the go to the primary care physician. Do not agree if they say, yeah, that's because you have myositis or because you have myasthenia or whatever. Because patients like you could have complications other than that. Everybody can have diseases outside of their own disease. And attributing the problem to the wrong disease is wrong because you're not addressing the main issue there. So be really on it if you experience problems that are brand new for you. Now with neuromuscular weakness and shortness of breath, this is kind of more stepwise unless there is other factor, let's say pneumonia or a new problem with congestive heart failure. All right, so interstitial lung disease, I'm sure you know about it. But I have to mention it because it is part of this topic and it's very important. Patients with polymyositis or dermatomyositis, 20-25, different statistics you can see giving a different numbers. Now, sometimes it may precede the diagnosis of myositis. In other words, it can occur before that. And I have patients who have had this lung problem for years, and then they become diagnosed, then the symptoms of myositis start after some time. So these are diseases, a group of diseases that cause scarring of the lungs. So instead of the lungs functioning normally, having normal structure like I was trying to explain to you, looking at like a tree with branches, there is scar tissue. And scar tissue anywhere, in the heart after heart attacks, in the brain after strokes, in the lungs after something like this or a lung infarct, means area that doesn't work properly, that has lost its integrity and its function. So as a result, these folks have problems with breathing. Because again, these pipes cannot be all be filled with air. And therefore, they have shortness of breath, they could have dry cough, they could also have fever. Whether it's a sign of fever being a sign of infection or a sign of autoimmune reaction in some of the symptoms, systemic symptoms that folks with myositis would have. Or some patients may have completely asymptomatic interstitial lung disease. Like I said, there is a spectrum. It's a different spectrum of diseases, and the patients could present differently. Now, if there are no symptoms and only X-ray findings, the observation is only observation is necessary. But when patients have interstitial lung disease, presentation, findings, symptoms, then they should be treated. Steroids or immunosuppressants or IVIG or rituximab. Now testing. And you folks say, how do we test it? With chest x-ray, you know, the old-fashioned chest x-ray still works, can diagnose. CAT scan gives you better information, but keep in mind, CAT scan gives you more radiation. So with each of the slices in the CAT scan, that's an x-ray picture, x-ray. So if you have 20 cuts through your lungs, that's 20 x-rays that you got. So next year, if you or in 6 months, you have 20 more X-rays. So if something gives you enough information, usually don't push for some kind of more complicated test that could give you exposure to more radiation potentially. CK could be normal with those folks. Again, pulmonary function test or spirometry is the key, because the pulmonary function test shows the function, right? The X-ray is a picture, and it doesn't tell you many things. And I'll give you an example completely outside of myositis. If you're looking at brains of patients who have multiple sclerosis, I'm sure you've heard about multiple sclerosis. You see in some patients so many spots in the brain, abnormal spots. And you think, oh, they're horribly disabled, and actually they're not. Compared to some brains that have a couple of spots, but in very bad areas, and they're significantly disabled. My point here is the function is what is important, not so much the image. And that's why we treat the patients, we don't treat the X-rays necessarily. And therefore, don't rely on the chest X-ray, push for spirometry to be done. Bronchoscopy, biopsy could be done, follow-up with pulmonary specialists, they specialize in those diseases. And one more time, it's not all interstitial lung disease. It could be other things causing those symptoms. Like I said, heart disease, medications. For example, these days we prescribe the so-called ACE inhibitors that they could produce cough. And it's a simple fix. You just stop that ACE inhibitor, you start some other medication of a little bit different group if you need to be on those medications. Side effects to pneumonitis or side effects due to the immune therapy could also be the reason for the symptoms. In some folks, actually about 85% Jo-1 antibody can be found. So the negative, see 85%, 15% means that they may have interstitial lung disease but not have positive antibody. Okay, so the antibody is not everything. It doesn't mean, yeah, you can see it in 85, but 15% may not have it. I know you had a talk on myositis and heart disease, but I'll just do a summary here. So myositis, inflammatory myositis can cause inflammation of the heart itself, right? It's called myocarditis. But it could also damage the blood vessels that supply the heart with blood, therefore supply the heart with oxygen. So in this situation, it's like heart attack symptoms, angina, we call them angina, chest pain, particularly with stress or with exercise, at times when there's higher demand for oxygen. And when does it happen? If we have to do something, let's say not walking but running or lifting something and so forth, same thing, blood vessels may not be necessarily damaged, but they may constrict. There may be spasm, just like you feel spasm in your legs or spasm in your stomach or in your muscles, the same way the blood vessels would go into spasm. And what happens? They constrict, there is not enough blood, the heart works without oxygen, chest pain is another symptom. So in other words, there are different mechanisms by which the heart could be affected in both of myositis. Now, if the heart muscle is affected, depending on what, it doesn't matter what it is, in other words, it could be inflammation or decreased blood supply, it may weaken. The walls may not be strong enough, and this could create congestive heart failure. And it depends which part of the heart is affected. Because you know there is right ventricle and right atrium, and left ventricle and left atrium. And if the right side is affected, patients may have swelling of the legs, bluish discoloration, big liver. And if the left side is affected, this will kind of go back to the lungs. They may have problems with breathing, pulmonary edema, and all that. Arrhythmias also could be seen, again, because of the same issue, that inflammation could be affecting areas of the heart that create this rhythm, this contraction. It's what we call a pacemaker, but not the pacemakers that they implant here in folks whose natural pacemaker that way. I'm talking about the natural pacemaker could be affected, and then the heartbeats may not be that synchronous as they should be. So folks who have cardiovascular disease could have chest pain, shortness of breath, palpitations. They could have symptoms, fainting spells. Why do they have fainting? And I'm not talking here about fainting, oh my gosh, I'm so happy when I fainted because I hyperventilated. Because fainting results from decreased blood supply to the brain in situations of higher demand. So if you are, again, doing something that requires more oxygen and kind of faster heart rate to compensate, then the brain may not get enough oxygen and boom, you lose consciousness, and that's what we call fainting. Cyanosis, or what I was talking about, this bluish discoloration of the lips, of the legs, and decreased exercise tolerance. And this may coexist with what naturally happens. You know, as we age, we accumulate more atherosclerosis in our blood vessels. We call this coronary artery disease, okay, which is a natural and unfortunate changes of the blood vessels with time. So if symptoms like this occur, of course, seeing at least your primary care physician, it depends on the level of comfort. You know, some people want directly to go to cardiologist, but this could be something really simple. But start with the primary. Of course, it depends on the insurance company, because some insurance companies will not let you go to a specialist without a primary. But some simple tests like EKG, echocardiogram, where with ultrasound they really look at your heart valves, heart muscles, how big all those chambers are. Holter monitoring, meaning they put a machine to monitor your heart rates. You go home, you do your stuff, and they just later on read all this data, and they can tell whether your heart rhythm goes in and out of rhythm. Very important, because many times patients do not necessarily have the symptoms. Some patients have palpitations. Somebody may have atrial fibrillation without even noticing it until they have a stroke. All right? So these are things that could be diagnosed with Holter monitoring. Stress test could be done. And stress test these days is done not only by running on the treadmill. They can do pharmacological activation of the heart. So the fact that you may not be so mobile and capable of walking, climbing stairs or whatnot, doesn't mean that stress test cannot be done. Injuries. Very big part of our lives, and particularly the lives of those who cannot ambulate properly. And this is very important, because many things could be under good control in your life and in your health. But one injury could actually pull you down, could kill you potentially. So that's why we have to keep those in mind. Most of the time they're due to falls, because our minds work faster than our legs sometimes, right? We want, I'm not 25 years old, but sometimes I think I am. And, I want to do things the way I did them many years ago. And same way you guys are, because your brains are young and healthy and working, but your legs may be not. So try to learn to live within your body so that you don't put yourself at risk from injuries that could potentially slow down the healing process and cause more trouble. So head injuries, concussion, contusion, different bleeds in the brain can occur. Bone fractures, pelvis, long bones, small bones. A few years ago, I broke my pinky, toe. You have no idea how much it hurt me. I was like, how is this possible? To have a tiny little toe broken and to hurt for 7 months like hell. Thankfully, I live in Florida, so I didn't have to wear closed shoes. But can you imagine, breaking a pelvis, breaking big bones? So it hurts, really hurts. But forget about the pain. Think about function, because even with this pinky, I have to limp and whatnot. Imagine pelvis and long bones. This means one has to be in bed, has to be immobilized, you lose more muscle bulk. Sprains and strains, of course, they hurt also. This delays physical therapy and whatnot. Cervical or lumbar disc herniation. This is painful too. I had one of those 2 months ago, could move 2 days I was in bed. And I can tell it hurts like hell. But try to avoid it. Physical therapy evaluation is really important before all this happens. Because the physical therapists, and we work with physical therapists, I really respect what they have to say. Because they can evaluate your current functional status. Not what you want to do, but what you are doing right now. And they can also evaluate you for needs, what you need. And I have an elderly friend. She doesn't have myositis, but she's like, I'm gonna die, and if I have to wear my high heels, I will wear them till I die. I'm like, there is no point. She broke her pelvis, then she stopped wearing those high heels. So, we have to accept certain things in our lives. So try to follow the advice of the physical therapist. Also, what needs you have for home is very important. Some railing, or adjustment of the stairs, or whatever, in your home, more light, and so forth. So you have to live in a safe environment. Braces, walkers, anything that a physical therapist feel could be helpful is for your benefit. So take your time also. I mentioned some of these things. Take your time. And it doesn't apply only for patients who have problems with muscle strain, but with everything. I have folks who have what we call orthostatic hypotension. Their blood pressure drops, even from that standpoint, because when you're mostly sedentary, then the blood pressure the blood vessels get lazy. They're like, I'm not going to work so hard because, he or she's sitting all the time. But when you try to get up, then the blood pressure suddenly may drop. And on top of everything, you have this decreased blood supply to the brain, putting you at risk to fall, lose consciousness, and have more trauma. So take your time. I advise patients, when you get up, have something right next to you to hold on to, so that in case you get a little bit dizzy, you can support yourself. And same thing, make sure the floors are good, they're not slippery. Lights and raising, I said that. And one more time, do not ignore what physical therapists advise you. Knee hyperextension. Some folks who have weak muscles in the front. The muscles in the back of the leg kind of take over and they pull the whole leg backwards. So this creates a lot of instability and imbalance between the function of those two muscle groups. And when they're unstable, they again put folks at risk from falling and damaging other structures. So folks who have hyperextension, they could have pain in the back of the legs or in the knees, also the sides. The knees may be unstable, they may give way, and because of this, they may have falls. So I just put it for just fun, some pictures with some bleeds in the brain. I told you, brain bleeding could occur with head injury. Now, with people who are older, sometimes you don't need a big brain head trauma to develop bleeding. So I would advise if somebody hit their head and has some symptoms, I'm a little bit nauseated, make sure you seek medical advice. Because what happens is, when we age, the brain kind of starts shrinking, unfortunately. Just like everything. It starts shrinking. And there are veins in the brain that kind of get stretched. They're not kind of nice and winding, but they are stretched. And even with minor trauma, these veins can burst and they can produce bleeding in the brain because of dural hematoma. And many of these can go unnoticed. Or, patient is fine, oops, next day, patient will be kind of in coma. So don't ignore light symptoms, nausea, if you have nausea, headache, with heavy trauma. Not because you have myositis. It applies to everybody who is in their 60s, 70s, 80s, when these shrinking processes start to take place. We call it atrophy, the endotensitory is atrophy. And some pictures of disc herniation. This day and age, every patient who has MRI, they hand the films in the past. Now they have the CDs, and patients go home and they come for a follow-up. They say, oh, I saw my picture. I may not be able to open it at my side because for whatever reason, universities block sometimes films from other people, from other institutions. But the patients look at their films. So what you can see is bulging discs. Again, you don't need to be a specialist to see how big, how nice it is. These discs are nice and flat with the bones, and boom, all of a sudden you have this bulging disc right there, pushing very important nerves going to the legs. So these patients may have numbness and tingling of the legs, more weakness, pain in addition to the pain in the back. And in the same way in the neck, this herniation here in the neck, and then you see nice and flat here, but in this area you see the bulging disc. In the neck area there is also other risk because there is the spinal cord. So when the spinal cord gets compressed, there could be serious complications because the arms of the patients could really get paralyzed from that. So also important symptoms to pay attention to: weakness, numbness, bowel, bladder problems. Rhabdomyolysis. You guys know about rhabdomyolysis, but I want to say a few words because it's part of the complication within myositis, the myositis group of diseases. So myoglobin, where does the word come from? Myoglobin is, you know about hemoglobin, you know about myoglobin. Hemoglobin is the storage of oxygen within the blood, right? And myoglobin also stores oxygen inside the muscle, in the muscle cells. When these muscle cells are broken down, like in inflammatory myopathies, there is muscle breakdown and cells kind of get disrupted and everything kind of spills out. So that myoglobin goes outside of the cell, and we have increase of the creatine kinase, which is an important enzyme there. And this myoglobin can be excreted in the kidneys. And when I ask patients, I don't ask them, oh, do you have myoglobinuria? But because they have no idea what I'm talking about. Many of them, who are new to that field, they may not know. But when I ask them, does your urine look like Guinness beer? They still may not know if they don't drink Guinness beer. But then Coca-Cola is something that everybody knows. So if the urine is dark, this could give you a hint, or give me a hint, and you of course, that there is muscle breakdown that goes on. Symptoms: muscle pain. Muscle pain could be in isolation if it is more significant than muscle weakness, fatigue. Now, many times patients kind of they say they're weak when they actually are fatigued and vice versa. So, not long ago, actually, I saw the wife of one of my colleagues who is an anesthesiologist. They went to clean a house because one of the parents passed away, and they cleaned the house, and the wife said, I was very fatigued. Turned out, when I examined her, she was weak. She was not fatigued. So she's a newly diagnosed polymyositis patient. But this is what she described to me, that she had fatigue. And fatigue is a very nondescript symptom. I could be fatigued if I work too much. Everyone could be fatigued, but weakness is something else. Some patients could be asymptomatic with milder situations. And you guys know that it could be life-threatening condition. So first of all, you all know that you have to drink plenty of fluids to make the kidneys work and clean all those products of myoglobin breakdown so that the kidneys don't get shut. Because when there's too much myoglobin there, the kidneys go into what we call tubular necrosis, and then patients they may stop working. So that's a dangerous situation. The other problem is when the cells get broken down, including the muscle cells, the potassium comes out and goes into the blood. Too much of potassium causes the heart to have arrhythmias. So during those arrhythmias, they could be quite dangerous. Some of them could be dangerous. So that's why by all means we want to prevent rhabdomyolysis, or if it happens, go to the hospital, because you maybe fluids by mouth may help, but it may not be enough. Why is this? Because patients have different absorption level. You know, just like maybe you've heard, oh, somebody has vitamin B12 deficiency. You take tons of B12, but the level doesn't even go up because you don't absorb it, right? Same thing is with, we cannot rely on by mouth absorption all the time, just like we rely on IV fluids. Same thing, low calcium, and calcium gets, calcium and potassium, they work kind of opposite way. One goes up, the other goes down, and vice versa. So in situation of hyperkalemia and high potassium in the blood, calcium goes up. Same thing, cardiac arrhythmias can occur. Okay, so electrolyte imbalance is properly managed in the hospitals, in emergency rooms. Of course, muscle rest has to, if you overwork, then you have to take rest. We put these people to rest a little bit so that their kidneys will catch up, and we hydrate them and we take care of that problem. Other causes of rhabdomyolysis. Okay, I'm going to talk later about other causes of dark urine, but now some other conditions can also cause rhabdomyolysis, even in folks who do not have myopathies or inflammatory myopathy specifically. Infections, and the mechanism is increased temperature, and viral infections or bacterial infections that are quite common can cause rhabdomyolysis. And if these infections are in patients who have myositis already, this could actually make the problem worse. That's why early recognition of infections is important. Medications, the cholesterol-lowering medications, the statins. And a couple of years ago when the meeting was here, I talked about statins in myositis, general anesthesia, neuroleptics, sudden stopping of Parkinson's medications. Like I said, patients could have myositis and Parkinson's diseases could co-occur. Chemotherapy agents, toxins, methanol, insecticides, mercury, carbon monoxide, venoms. We have a lot of snakes here. Snake venoms, hornets, wasps, lots of them. Redback spider, bees, they can cause rupture as well. Drugs. I hope nobody's fear of cocaine. We're not going to have cocaine party after that. But cocaine and amphetamines, horrible drugs. They can cause muscle disease, they can cause strokes, they can cause rupture of blood vessels, aortic dissection, all kinds of vessel dissections. The worst drugs under the sun. Alcohol and heroin. If you drink too much alcohol, and patients without chronic alcohol abuse, shall I say, they could have myopathies also, damage of the muscles, muscle breakdown, not inflammatory. That's toxic myopathy. But again, what I'm talking here is other causes of myositis. That's why if you have underlying muscle disease, yeah, a glass of wine probably is good, but not too much, because that alcohol toxin contributes to the muscle breakdown. Other foods, blue crankhead parrotfish, Mediterranean quail. I'll show you a picture because I'm like, what is that fish? I've never seen that. I don't remember eating it. Muscle trauma or overexertion, physical factors, particularly here in Florida, hyperthermia can cause muscle breakdown. So make sure you have, don't stay in the sun all day long. Same thing is hypothermia, the extremes. Any extremes can damage the muscle. Because in hypothermia, when you're cold, what do? You shiver. And your muscles work extra to produce a little bit more heat throughout your body, your core. Near drowning also. or any electrolyte imbalance from other reasons, not necessarily from muscle breakdown. So here are these guys. This is the blue-handed parrotfish, which I found in close rhabdomyolysis. I have no idea where it lives, whether they serve it in the restaurants, but I'll pay attention from now on. Quails, I know. My father was a hunter, and he would hunt a lot of quails back in Bulgaria, where I'm originally from. And I don't know if the Mediterranean is the same one that we have, but quail, what can I say? Now, other causes of dark urine. This is not necessarily because of myoglobin in the urine, but just discoloration of the urine from another reason. And you know, liver disease, jaundice. If you have jaundice, in certain types of jaundice, the urine can become dark too. Okay? So liver disease of any kind, whether it's hepatitis, infectious hepatitis, or whether it's cirrhosis, or pancreas, because the pancreas blocks, pancreatitis could block the outflow of the bile, and that blockage of the bile can increase can cause jaundice and dark urine. So same mechanism, bile duct stones, urinary tract infections can make urine dark and murky on top of that. Kidney bladder stones, blood in the urine, if it stays for a longer period of time, it's not bright, it becomes dark. So that could cause change of color. Hemolytic anemia, this means red blood cell breakdown from different causes. Porphyria, very rare disease. Have you heard of porphyria? You don't, but you've heard of werewolves, right? And many people think that actually those kings, for example, the British kings, I believe the Charles family, I might be wrong, don't quote me on that. But because it's a genetic disease and it's dominant, meaning every generation will have, these are people who are afraid of the sun, because in the sun they get horrible blisters on the face. And how do you treat this? By giving blood. So drinking, you know, those vampire stories, maybe really based on real diseases, and porphyria is that disease that is still today treated with blood products, hematin. We give IV. So these people also have dark urine. The vampire have dark urine. Medications for malaria, antibiotics, flagyl, muscle relaxants, laxatives. You know, many folks take senna for constipation, and that could cause darkness of the urine. Very commonly used medication. Fava beans are not so common here, but fava beans are common for the Middle East, Mediterranean. I like fava beans. They could cause some trouble, though. Aloe, beets, rhubarb, and in drug-induced hemolysis, again, drugs can cause red blood cells that carry the blood, the oxygen in your blood to get to break. Cephalosporins, levofloxacin, penicillin, non-steroidals, or levodopa, which is for Parkinson's disease. Now, folks with myositis could have generalized symptoms, not because they have an infection or have anything else going on. A little bit of fever, chills, fatigue, muscle pains, and joint pain as a sign of autoimmune process, you know, non-specific. And I'm not talking about fever here, 104, but it could be kind of a little bit, not normal, not too much, but a little slight fever in all these symptoms. Myositis can be associated with other autoimmune conditions, like lupus, rheumatoid arthritis, scleroderma, Sjogren's, or thyroid disease. Also, some anemia, anemias that are most, you've heard probably about aplastic anemia. So these are also thought to be related to autoimmunity. So it's not uncommon. And like I said earlier, folks can have anything else, unfortunately, other diseases. They're not just, I mean, the fact that you have stuff, we have a saying in my language, if your dog has fleas, doesn't mean that it cannot have ticks. So it can have two things going on. Raynaud phenomenon is also common. We call it Raynaud phenomenon. But it's low tolerance to cold, and all those the fingers, the nose, the ears, they may become discolored. And in some patients, they could be really pale, and you can see in this picture how pale they are, white compared to the rest of the hand, or they can be purple. So this is kind of dysregulation of the response of the blood vessels, and they may constrict and cause the paleness because there is not enough blood going there, or there could be too much blood there. So bottom line dysregulation. Now don't think that we living in Florida, we're good here with the cold fingers and all of that, because we have air conditioning and my hands are always cold. So imagine a patient with Raynaud will really be comfortable. I have a patient who wears gloves everywhere she goes. Patient with myositis and Raynaud. So again, it's not pathognomonic, meaning typical for myositis. It could be seen in many other autoimmune diseases. I'm just saying what can also be seen in folks who have myositis. Calcium deposits, not all those, they could occur anywhere, not only in the skin, but they could be in the muscle, in connective tissue, and then we call this calcinosis. And conceivably, in the skin, it may be just cosmetic problem, but it affects the muscle or the connective tissue or some joints. It could cause mechanical problem too, and some pains. So it could be an issue for folks. Deep venous thrombosis. Deep venous thrombosis is a serious condition, and we have to keep this in mind. Why? How does it happen? First of all, the arteries, first of all. The arteries give blood everywhere, to the brain, to the periphery. And then the blood, after the arteries deliver and the capillaries deliver the oxygen to the tissues, then the bad blood is carried by the veins. So in the veins, the flow is kind of very slow, the pressure is very low there, not like in the arteries, very big pressure. So in patients who are not so mobile, if they are more sedentary, this could be a risk for forming clots in the veins or having deep venous thrombosis. And some of the symptoms are, of course, pain, swelling, redness, and warmth of the legs. So you can appreciate how the skin is different on both sides. This leg is really shiny and red, and this patient really needs to go to the doctor or to the emergency room. Because when there is blockage of these vessels, the veins, then these clots can go up to the lungs and cause pulmonary embolism, which is a life-threatening condition. At this level, it's treatable. It's very treatable. I'm not saying pulmonary embolism is not treatable, but it may be deadly because if the clot is big enough, it could block the lungs, the blood vessels in the lungs, and cause sudden death. That's one of the causes of sudden death. Now, there are groups of folks, probably about 20% of the patients who have persistent opening in the heart. That opening connects the two of the chambers that were normally connected during fetal, when the babies still grow in their mother's womb, because it's open, that opening kind of keeps the lung, because the lung is not working when the baby is still growing in the mother's womb, right? The baby that is not breathing there in the water, in the fluid. So the lung is not working. So in order for the blood to go directly, the blood from the placenta to go to the baby's brain, there is a hole in the heart. We call it foramen ovale. In some folks, like I said, 20% doesn't close when you get born, after birth. So we call it PF4, patent foramen ovale. So in folks who have clots in the legs, sometimes these clots can bypass the lungs, go through that hole and go to the brain and cause strokes. So that's another reason, not only because of the lungs, but because of the brain and elsewhere, why we care about taking care of venous thrombosis early on. So how to avoid venous thrombosis? Now, if you can, like they say the commercials, or if you have done long flights from here to Europe or here anywhere, longer flights, they say move your legs. Even if you cannot walk, just move, make these muscles work. Because I told you, these veins are kind of slow, the blood flow in them is very slow. And when the muscles contract, they pump, they make those veins pump the blood upward. So even this simple thing helps. Or those who cannot move, just massaging the legs will help the blood. Not just stay still and relax, but move further out and get going. In some patients, of course, compression stockings can be used, aspirin or anticoagulation, who are at really big risk. And of course, this is treated with anticoagulation. If there is infection on top of that, which is called cellulitis, these folks have to be also on antibiotics that treat skin disease. Very important. So look at your legs. Clots can occur anywhere, but most commonly they occur in the legs. Some patients are predisposed to forming clots. Even without, like I said, myositis. Young people, we call those hypercoagulable states where they make clots. Pressure ulcers. Now normally the skin also needs good blood supply, right? So when a point or spot on the body is compressed for a longer period of time, then there's not enough blood supply to those areas. And this could be a risk. I said, oh my gosh, I have to finish it.
Well,
this would create a risk for what we call decubitus ulcer or pressure ulcer or bed sores and whatnot. So usually these occur on body prominences where the bones are more exposed. Very important, folks who have braces, because the braces here in the legs, they compress bones that are sticking out. They're not so protected by muscles surrounding them. So the hips also, elbows, the ankles, like I said, or the head. Folks who are in bedridden, they could have pressure sores on the back of the head. So in order to avoid, we have to avoid long-lasting pressure in the same spot. With the braces, move them, off of them, remove them, let the blood flow. Make sure you speak with your therapist or those people providing the braces. Let them know they are not comfortable, so that they would make padding and would make them really better for the shape of your legs and for your muscles. They have to be addressed immediately because complication, first of all, they don't heal greatly. And if there is diabetes or some other problem, medical problem, it makes things worse. And then these sores can be complicated by infection. I don't want to scare you. This is how it looks at the beginning. You may say, oh yeah, you have a little bruise here. But watch again, this is important also for the caregivers. Pay attention to the skin, very important. Okay, this is stage 1, this is stage 4. This is hard to cure and treat. Exercise, probably I'm not going to spend enough time on exercise because here enough about that, but many times what I see in patients, they go through physical therapy, they show them the exercises, they go home, they stop doing physical therapy. But the whole point is you can't go to physical therapy for the rest of your life. But the exercises that they show you, you can do. Now, provided if there's no crazy equipment involved, but some of the exercises you can certainly do. Even if you're sitting watching TV, you still can do some to help with your muscle specific. Some protection is very important, like a part of general measures, because many folks may have sun sensitivity. Not only the folks with dermatomyositis, but also some medications can increase the light sensitivity. So protect, use sunscreen, there could be itching. Some folks, particularly women postmenopausal, perimenopausal, more osteoporosis because also of the medications, because of the more sedentary lifestyle. that's increased. Infections can be related to the immunosuppressive therapy, so avoid sick contacts. Sometimes we're too shy to say, okay, you're sick, just don't talk to me today, or put a mask, or you put a mask. Don't be shy. Those of you who are on immunosuppressive therapy, protect yourself. There is nothing wrong about saying, okay, I don't want to get sick. So even early mild symptoms and seek help, because it really matters. For example, patients who have normal immunity, if there are 5 cells, 6 cells in the urine, the white blood cells, yeah, we call it, that's probably not urinary tract infection. But the patient who is on immunosuppression and their white count is not necessarily normal, that could be very meaningful. So it's also important to inform providers who don't know you that you are on immunosuppressants, and they will know right away that you're more prone to having infections. I wish I had more time, but you know about these topics about neoplasms, that polymyositis, dermatomyositis more than polymyositis, could be actually associated with malignancies, particularly early on in the disease, more commonly dermatomyositis, less commonly polymyositis, but both can do that. Mostly males more than females. And screening is very appropriate, particularly at the beginning of the disease. Screening for cancer. That's why I want my patients with DM or PM to have regular screening, make sure that there are no hidden cancers. And we call these disorders, it's not only PM and DM, called the paraneoplastic, meaning that they could exist around malignancies. And they could be the first sign, and then the malignancy shows up. In a way, I tell patients who have paraneoplastic diseases, not only myositis, that maybe they're lucky to have that disease because this prompted us to do surveillance on a regular basis and catch a cancer early on. So we're not, if there is something good about it, probably that's the good part of it. That we, by doing surveillance, we can catch cancers early on. And of course, there are different cell types, different types of cancers involved in these. Different areas of the world have kind of more, for example, Asian people more bone, brain, mesopharyngeal. So the point of my talk again is not to scare you, but to give you some information, to kind of empower you, knowing some things, and how to prevent bad diseases from happening. And it's anonymous, but I kind of like it. Knowledge becomes power only when we put it into use. So with this, I finish, and I am open for questions, and I hope I will be able to answer you. Thank you very much.